Thank you very much. So at MD Anderson Cancer Center, we perform nearly 20,000 PET-CT scans each year. We try to tailor these protocols to the individual indication for the patients, and I'll give you some examples of how PET-CT, even though performed with FDG and more or less performed the same way time after time, can be structured and tailored to, again, answer the clinical question and to obtain the best information for a particular patient. The topics I'm going to cover in this presentation include the scan acquisition parameters, the use of contrast in PET-CT, and then some words about dose optimization. For scan acquisition parameters, in the United States, the PET-CT scans are allocated on the basis of how they're performed, basically in 3 separate codes. And so there's a code for the reimbursement scheme for a limited area PET-CT scan or PET scan, a skull base to mid-thigh PET scan, and then a whole body PET scan. We actually tend to use the limited area very infrequently. This is something that we don't tend to use very often, but when it is used, it would be things like evaluation of a pulmonary nodule for perhaps where you only wanted to image the lungs to look at the pulmonary nodule to determine whether it's malignant. But an area that is developing is positron emission mammography. There are dedicated scanners that can obtain PET images of the breast for evaluation in a very high-resolution fashion for looking for breast carcinoma or for characterizing tumors within the breast. And being a specific anatomic region, this is actually an example of that limited area PET scan. So here's an example of a patient with multifocal breast carcinoma that we performed at MD Anderson Cancer Center using one of these positron emission mammography devices. We can very nicely see the extent of disease within the breast in both CC and MLO projections, as well as seeing nodal metastatic disease in the axilla. Again, this is not a frequently used indication for PET scanning, but would fall under that category of limited area. As it sounds like is the case in Kuwait, the majority of our scans are actually the skull base to mid-thigh or perhaps vertex to mid-thigh. The majority of tumors we deal with are in the torso, they're in the lungs, they're in the abdomen, and this is our bread and butter mainstay PET-CT scan for oncologic imaging. We use it on a daily basis for patients like this, newly diagnosed lung carcinoma. We can see a mass in the lung that's very hypermetabolic, and we're doing our screening to see what the extent of that disease is. We reprocess these in several different ways. So here's an example looking at this pulmonary mass. This would be our standard soft tissue algorithm, and we can see that this mass is very metabolically active. We also go back and reprocess the CT images to a lung algorithm to do some edge enhancement and sharpening of the images to really better see the extent of disease within the lungs. And you can see that this is actually a very nice quality CT image. Despite being performed as part of a PET-CT scan, we can very well see the detail of the pulmonary parenchyma, again confirming this mass to be hypermetabolic with some extension into the adjacent pulmonary parenchyma. Whole body scans would go from the vertex of the skull all the way down to the feet. So this is a true whole body scan. The entire patient's body is included in this scan acquisition to allow a metabolic assessment of the entire body. We need to be a little bit careful in this case because our standard CT acquisition encompasses a 50 centimeter field of view. This is our best resolution for the CT portion of the examination. But the PET scan for most scanners goes all the way out to the edge of the acquisition, which in many cases is around 70 centimeters axial field of view. So you can see that the two of those are a little bit different. There's a difference in the field of acquisition of those two. So if we were to apply attenuation correction using that 50 centimeter CT to a 70 centimeter PET scan, the arms would be outside the field of view and we would arrive at some attenuation artifacts. In order to account for this, we can actually reprocess and reacquire that CT scan out to a full 70 centimeter field of view. Now you can see that the image quality at the edges of the field is a little bit lower. The CT is really not meant to go all the way out to 70 centimeters. But by understanding and capturing the detail of the soft tissue and the bone out to this 70 centimeters field of view, now we can match the CT field of view with the PET field of view and acquire images that go all the way out to the edge of the body with appropriate attenuation correction. So we need to make sure for these whole body scans that that attenuation correction CT scan does go out and encompass the full 70 centimeter field of view. We use this application for patients with melanoma. We use it in cases of multiple myeloma, and we also use it for patients with cutaneous T-cell lymphoma and mycosis fungoides. So these would be our most frequent indications for whole body scans. So here's a patient with metastatic melanoma. We can see that this melanoma is involving the soft tissues of the arm. We can see that there's some axillary metastatic disease and some osseous metastatic disease as well. But we do want to encompass the extremities in this case, since melanoma can spread to soft tissues throughout the body. When we're dealing with patients with melanoma, I also make an effort to look at the non-attenuation corrected images. So cutaneous sites of disease, because of the attenuation correction algorithm employed with PET-CT, can sometimes be suppressed. The skin activity can be lower than it actually is because of that application of attenuation correction. So I always try to make sure to look at these non-attenuation corrected images to perhaps highlight areas of subtle cutaneous activity. Here's a patient with multiple myeloma. Again, this can involve any area of the skeleton, so we want to make sure to do a full skeletal survey when looking at these patients to determine the extent of marrow involvement and to look for plasmacytoma. In this case, we can see that this patient also has a large plasmacytoma involving the rib on the right-hand side. And then patients like this with cutaneous T-cell lymphoma, mycosis fungoides, can involve the skin and area of the body, so we routinely do a full body survey to look for sites of disease in these patients. Now, occasionally we'll do whole body scans in patients with known tumors of the lower extremities, particularly osteosarcomas, primary lymphoma of bone. We want to make sure to include those areas in the scan. We may also do a whole body scan in the patients where there's symptoms referable to the lower extremity, but you need to be a little bit careful about this because patients will oftentimes come in and they'll have knee pain and ankle pain and things like that that are just orthopedic problems and does not necessarily indicate that you need to extend the PET-CT scan all the way down to the feet. But if the patient says, you know, a few weeks ago I all of a sudden developed severe pain in my mid-thigh, then that would be a case where you want to make sure to include that area in the scan, and you might perhaps extend it to a whole body scan. Now, even within these frameworks, the regional scan, the orbits to thighs, and the whole body scan, there are some additional techniques we can use to really tailor our scan to the clinical question, to the type of tumor that the patient has. One of these is to do a scan that goes from the vertex to the thigh, but with high-resolution imaging of the head and neck. And we use this for patients with primary carcinomas of the head and neck, patients with thyroid carcinoma, and patients with orbital tumors. So for these types of scans, we actually do two separate acquisitions. We first do the scan on the right-hand side of the image, the scan from about the vertex of the lungs down to the proximal thighs. Once that scan acquisition is complete, we then do a second acquisition. We scan from the vertex of the skull down to about the aortic arch. We lengthen the scan acquisition in this case so that we're getting more counts. It's actually a little bit shorter acquisition so the patient can stay very still during that scan because we're very concerned about anatomic registration between the PET and the CT in the head and neck. So this is an example. This is a patient with a carcinoma ex-pleomorphic adenoma arising from the right submandibular gland. And very nicely we can see the extent of disease because of this high-resolution scan of the head and neck. Then we would complete the scan and look at the rest of the body to look for sites of distant metastatic disease. And in this case, there was no evidence of disease elsewhere in the body. Another example, this is a patient with newly diagnosed nasopharyngeal carcinoma. This is the diagnostic CT scan. We can see a large mass arising from the left nasopharynx, eroding into the left skull base with some perineural extension, and even some disease extent into the intracranial compartment along the nerves and vessels. Large nodal metastatic disease to the left retropharyngeal lymph node. Using this technique, we would acquire the whole body scan, the scan from the vertex of the lungs down to the thighs, and then later, about 80 minutes after injection, the vertex of the arch, vertex down to the arch. Notice that this scan is done with the arms up, so we remove the arms from the field of view. The second scan is done with the arms down, so again, the arms are out of the field of view, optimizing the acquisition in both cases. As far as CT processing in this case, we acquire again at 50 centimeter field of view for the CT, but then we reprocess it down to a smaller field of view around 25 centimeters, which gives us added CT resolution, and we can furthermore process these images to give us very nice bone algorithm to look for sites of osseous invasion, as we saw in this case. So you can see even without intravenous contrast, we can very nicely see the extent of disease in this case, not only the large primary nasopharyngeal mass, but the invasion of the paranasal sinuses and of the skull base. And we can even nicely see the extent of intracranial extension in this case. Here's a case of a patient with a newly diagnosed orbital mass that was discovered on anatomic imaging. We can see on CT that this mass is extracolonal along the medial margin of the left orbit, displacing the extraocular muscles. And when we look at the PET-CT, the PET portion of the examination, although the mass does show some activity, it's certainly less than would be expected for lymphoma or other malignancy, and this turned out to be a case of orbital pseudotumor. We sometimes do scans where we would do a vertex down to the proximal thighs, but with a high-resolution brain image included. Now, I'm not going to speak about neurologic imaging and dedicated brain imaging. My colleague, Dr. Fry, will speak more to that later. But there are cases in which we would want to acquire a high-resolution brain as part of a standard oncologic scan, and that would be patients with cerebral lymphoma, patients with known cerebral metastatic disease, or primary brain tumor which may have a predilection to metastasizing outside the brain, such as in the case of medulloblastoma. And using this algorithm, we can get very high-quality, high-resolution 3D images of the brain to complement the images acquired of the remainder of the body. Now, it's very important when looking at brain imaging to keep in mind, as my colleague mentioned earlier, about the importance of windowing, that it's possible to obscure sites of disease based on the intensity of activity. So if we look at this patient with lung carcinoma, initially looking at these brain images, we don't see too much there. It looks like there's just fairly normal physiologic activity throughout the brain. But if we window this out and get to the appropriate windowing level, we can actually see that these areas of leptomeningeal metastatic disease are indeed metabolically active beyond the physiologic activity within the cerebral cortex. But we need to make sure to window the brain out to the point that we can see the gray-white differentiation. Dual time point imaging is a concept that's been around for a number of years, and it's based on early studies that saw that the intensity of activity in the signal to background changed over time. So this is an early study by Val Lowe and his colleagues at Duke University, where they looked at the intensity of uptake in pulmonary nodules over time and found that as time went on, the intensity of activity tends to rise in these pulmonary nodules. See if I can use the... So you can see that in most of the malignant nodules, the SUV, as it's measured, would increase the longer the time went between the time of injection and the time of scanning. And so although some of them remained relatively flat, the majority of malignant nodules didn't tend to increase. The SUV tended to rise over time. Whereas the benign nodules, the majority of these tended to remain stable, although a few did rise as well. So this led to the concept that perhaps in cases like this, where we have an indeterminate pulmonary nodule on CT, we perform a PET scan and we can see that the SUV of this nodule is 1.7. Falls into kind of an indeterminate range, and we're really not sure what to do with that. The concept is that if you come back and image at a later time point, if that SUV increases, and in this case it rose to 2.3, a 35% increase in SUV between imaging at 60 minutes and 90 minutes, that would be more indicative of a malignant nodule. And this was indeed biopsies and turned out to be a bronchoalveolar carcinoma, or what is now termed adenocarcinoma in situ. So the people who believe in dual time point imaging tend to use this as a problem-solving measure for these cases in which the activity is in that indeterminate range. But as you saw, even in that initial study from 1995, there are benign nodules that increase in intensity and there are malignant nodules that stay stable in intensity. So this is by no means a definitive proof of benignity or malignity in pulmonary nodules, but it can be a problem-solving technique. Respiratory gating is something that is increasingly being employed, and there's a lot of interest in this, particularly with regards to radiation therapy. This is used in patients with pulmonary nodules and masses, but can also be used in other structures in the body that change position with respiration, including liver lesions. There are numerous studies looking at the technical factors with regards to respiratory gating, the effect on SUV and lesion conspicuity, but there are very few studies on whether this actually makes a difference, the outcome to the patient, the medical impact of performing respiratory gating. So these are a couple of examples that we've done at MD Anderson Cancer Center. This is kind of your classic pulmonary nodule that rises and falls during respiration. You can see that this nodule has a fair degree of transit. There's several centimeters worth of travel of this pulmonary nodule with respiration. But we also see nodules like this, a large apical pulmonary mass that changes very little in position with respiration. So you can see that the added time and exposure of respiratory gating in this case really was not helpful. Here's another upper lobe nodule with very little translation during respiration, and another basilar pulmonary nodule that changes very little. So it's not really clear in which cases respiratory gating is going to be helpful versus not helpful, and we don't tend to employ this on a routine basis, but may use it very specifically in cases where radiation therapy is planned and they want to know how far this nodule is traveling for the purposes of radiation therapy planning. That brings me to the last topic under the technical factors for PET-CT, and that is radiation therapy planning. There are patients that we know are going to radiation therapy, and we can use PET-CT performed in a radiation treatment planning position to aid them in determining treatment volumes. And we know based on the literature that there's a change in about 20 to 30% of management when PET-CT is used for radiation therapy planning over CT alone, and that PET can frequently change the gross tumor volume. So here's a patient with newly diagnosed nasopharyngeal carcinoma. We can see the primary tumor up in the nasopharynx, and we can see some nodal metastatic disease. Here's an axial image from that scan showing the primary tumor in the nasopharynx, as well as the nodal metastatic disease. Now you can see in this case on the CT that there's some stipulations along the skin, and that's from that mask being in place. So the patient was actually imaged in the treatment mask that they will be in during the radiation therapy planning. So it maintains consistency in the position of the patient between the PET-CT scan and their eventual radiation therapy, and this can then be used to derive treatment volumes for the purposes of radiation therapy planning. There are some barriers to the use of PET-CT for radiation therapy planning. Oftentimes the PET-CT has already been performed, so the patient's being worked up for their malignancy. They have their PET-CT scan for staging purposes. They're determined to be a candidate for radiation therapy planning, but now the PET-CT has already been performed, and that may not have been performed in that treatment planning position with a flat table and appropriate positioning. I'll next talk briefly about contrast administration. There is added value with the administration of contrast with CT and PET-CT. That includes both iodinated intravenous contrast as well as other contrast agents. But we don't tend to use this routinely. There are adverse reactions to contrast material. There perhaps may be some added radiation exposure by optimizing the CT with contrast. There's added cost, and there's some protocol considerations. We can use gastrointestinal contrast material as well as intravenous contrast material, and there are many options to use for each of those. As far as the protocol, when we do contrast with PET-CT, we basically have to inject the contrast and then perform our attenuation correction CT, vertex to thighs, orbits to thighs, etc., with really inability to tailor that protocol to the same degree that we would normally consider. So for example, for neck CT, we would use a straight axial orbits to upper chest for our PET-CT, but for our diagnostic neck CTs at MD Anderson, we do an angle tilt to get around the dental artifacts, and we use a narrow field of view. For the chest CT, we use full inspiration, arterial phase, high resolution. We can replicate some of that with PET-CT, but not all of it. For abdomen and pelvis, we may use multiphasic CT scanning, arterial phase, portal venous phase, delayed phase. We may give rectal contrast. These are all parameters that we cannot really replicate with the PET-CT scan. But here's an example of a case we did recently of a patient with gastrointestinal stromal tumor. You can see that the CT portion of the PET-CT was performed with iodinated contrast and oral contrast material, and we can very nicely see the areas of the tumor that are metabolically active versus those that are less metabolically active. And in fact, the CT with contrast can help us identify areas of the tumor within the peritoneal cavity, such as here in the left abdomen, that show relatively lower activity on PET scanning, but are nevertheless important to understand as far as the tumor staging. This is an example of a study that was performed a few years ago looking at who's using contrast in their PET-CT scans in a U.S. study. And what they found is that about a third, or a quarter of patients, of centers rather, were using intravenous contrast. So about 25% of centers were using contrast in very few patients, 1 to 25%. 24% of studies, centers were using it in about 26 to 75%, and about 1/5 of the centers were using it in most of their patients. So it's a little bit across the spectrum. With GI contrast, about half the centers were using it in most of their patients, and others were using it less frequently. So it's by no means widespread. At MD Anderson, we're currently using contrast in maybe 10% or so of our patients. So it's a very select patient population group that we think it may help. Just a brief review of the literature to look at the use of contrast in PET-CT. It really depends on the type of tumor you're looking at. So for patients with lymphoma, we're very good at identifying lymphoma, staging lymphoma, and looking at response assessment, even without contrast. And you can see in this case that the sensitivity and specificity are nearly identical for whether you perform the PET-CT in a low-dose fashion or whether you perform it in an optimized fashion with contrast enhancement. Really didn't make a difference for the overall staging of the patient. For subsequent imaging of lymphoma, again, the numbers are very similar. We're very good at characterizing lymphoma with PET-CT with or without contrast. Malignant melanoma, we found in this study that was published in 2011, that the sensitivity and specificity did in fact go up between the non-contrast CT, contrast CT, and then PET-CT performed with and without contrast, and that the best performance occurred with contrast enhancement of PET-CT. The caveat in this case is that the addition of contrast to the PET-CT didn't change the stage in any of the patients they looked at. Finally, in this study looking at uterine carcinoma, both cervical and endometrial, they did find that the sensitivity and specificity increased slightly with the use of contrast, and perhaps most importantly, the number of equivocal findings decreased to 0. When contrast was used. So it increased the confidence of the readers and allowed them to arrive at a better diagnosis with the use of contrast in these pelvic tumors. In head and neck cancer, particularly with regards to cervical lymph nodes, the sensitivity and specificity were higher with contrast enhancement on their PET-CT compared to the values without contrast enhancement. So you can see it depends on the type of tumor. Lymphoma, melanoma, maybe not so much of an impact. Pelvic tumors, gynecologic malignancies, head and neck cancers with necrotic lymph nodes, there was an added value of contrast enhancement. So at MD Anderson, here's our practice. We use contrast and PET-CT in our lymphoma population, but we use it to replace separately acquired CT scans. So in that case, we're only doing one single study rather than doing PET-CT plus diagnostic CT. We do it in gastrointestinal stromal tumors, desmoplastic small round cell tumors. We're increasingly using it for our phase 1 studies, our protocol patients, as well as some other added indications. In the last few minutes of this presentation, I'll finish talking about CT dose. It's important to decrease the CT dose as much as possible, yet maintain diagnostic imaging. And one of the techniques that we've employed is tube current modulation. This is a concept where instead of setting the tube current at a single static value through the scan, we actually can tailor that. Most modern scanners can do this to vary the MA depending on the region of the body that's being imaged. And so you can see that the MA in these cases drops fairly significantly as you go through the lungs, may go back up through the pelvis, through the head, through areas where there's increased soft tissue attenuation. So for example, in the head and neck, we can see that the images acquired in the scan on the left-hand side with 300 MA are very similar to those acquired with 70 MA, much lower radiation exposure on the right-hand side. Similarly, through the lungs, 300 MA versus 126 MA, 300 versus 170, and 300 versus 131. So despite cutting the radiation dose significantly on those right-hand side of images, we're maintaining image quality through the use of tube current modulation. And this was a study we did at MD Anderson looking at the effect of that tube current modulation based on BMI, and found that the most dose savings, sometimes up to 70%, occurred in these patients with relatively low body mass index. So heavier patients, you're going to need to give higher dose to get adequate quality CT images. But lighter patients, we can cut back significantly on the extent of radiation exposure. And we can see that this is per region. The greatest savings is in the head and neck, but with fairly substantial dose savings in other parts of the body as well. So we made some changes over the years at MD Anderson. We made a change from 2D acquisition to 3D acquisition, which allowed us to cut our dose from 39 millisieverts down to about 28 millisieverts. That occurred back in the late 2000s. We've since optimized our CT acquisition using tube current modulation bismuth shields, and now that the total dose from our study is less than 20 millisieverts, and we're constantly trying to decrease that as far as possible. So in summary, there are ways that we can tailor our scan acquisition to answer the specific clinical questions based on the patient's tumor type, things like scan length, reconstruction, and localization time. Intravenous contrast is being increasingly used. I don't think it's a tool that should be used in all patients, but for select patient populations, it may be able to increase our sensitivity and specificity and help us with our confidence in the interpretation of the scan. It may certainly be used in some instances to eliminate separately acquired PET-CT scans and diagnostic CT scans, and thereby reducing dose and cost for the patients and for the healthcare system. And finally, dose is an increasingly important thing to consider when performing scans. We want to minimize the amount of radiation exposure for our patients while maintaining diagnostic image quality. Thank you.
So Dr. Eric will present another presentation on the title of Update and Response Assessment with PET. You may start.
Thank you. So we'll move right on into the final presentation before this morning's break, and that is an update and response assessment with PET. As I indicated in the first presentation, the majority of scans that we do, this is the actual indication. So we do some PET-CT scans for initial staging of disease, but particularly at a place like MD Anderson Cancer Center, the majority of the scans we performed are in patients who are being treated for their disease, and we're looking for the response to therapy. The goal of response assessment with PET-CT or with any imaging modality is really to predict the long-term treatment outcome prior to the completion of therapy. We want to know, is this patient responding to the therapy? Should we continue on this therapy? Or do we need to change the therapy to something more effective if that patient is not responding? And the concept that you'll see out there is use of imaging as a biomarker. We want to use this as a non-invasive means of assessing the biology of the tumor to understand the best course of therapy and to develop patient-specific treatment strategies. It was mentioned several times yesterday that the goal is patient-specific therapy and personalized medicine. In the assessment of response, we can look at things like objective tumor response, tumor shrinkage. We can look at time to tumor progression. And as I mentioned earlier, really the framework that's been in place for a number of years is RECIST, the Response Evaluation Criteria in Solid Tumors. This is really based on anatomic imaging and CT in particular. It's based on tumor sizes and bins things into these four categories: complete response, partial response, progressive disease, and stable disease. Now, although this is a very robust system for CT, it has its limitations. RECIST 1.1 was developed in 2009, and it has its limitations with regards to functional imaging. And this is really all it has to say about the use of PET-CT. The PET is a modality, a technology that's in rapid evolution. The low-dose CT portions of a combined PET-CT are of limited use, but perhaps the CT study could be used in RECIST evaluation if it's performed with IV and oral contrast, as we discussed in the previous presentation. Their use of PET-CT in RECIST 1.1 just says uptake greater than twice that of surrounding tissue can be considered positive. This is not the way we interpret PET-CT. I think this is a very rudimentary way of looking at PET-CT. So clearly there's more that needs to be done with developing response assessment using metabolic imaging. There are, however, some areas where PET can be incorporated into response evaluation, and one of the limitations, for example, with RECIST is that lesions have to be discrete. You have to be able to see a lesion, put calipers around it in order to be able to generate measurements for RECIST. So we see tumors like this all the time, a patient with newly diagnosed esophageal carcinoma. Very difficult to measure on CT. Are you measuring the wall? Are you measuring the wall-to-wall diameter of the esophagus? How long is the tumor with regards to esophageal extent? And we know from studies that PET is very well situated to be able to determine the extent of disease involvement of the esophagus and be used in response evaluation. And so there is definitely a need for use of PET for metabolic assessments in cases where RECIST measurements don't provide the adequate degree of information. Bone disease is another area that's not RECIST measurable, but we see a lot of patients that have bone disease that can be evaluated with FDG-PET-CT. So moving beyond RECIST 1.1, These are some early studies that were performed at MD Anderson by several of my colleagues looking at gastrointestinal stromal tumor. This was one of the first tumor models where we began to understand that anatomic imaging by itself doesn't give the complete answer, and that the tumors may actually increase in size or stay stable in size despite, as we can see, a very robust response to metabolism with Gleevec therapy. And that led to some very cleverly titled articles such as "We should desist using RECIST, at least in GIST." The goal of response assessment with PET is to generate data like this, where we can see that by using metabolic activity, we can very nicely stratify patients between responders and non-responders and even intermediate responders based on the degree of metabolic assessment with PET-CT. And the earlier we can do that in the course of therapy, the greater our flexibility in determining adequate tumor response. We need to make sure to do these scans in a very regimented fashion, controlling as much as possible things like localization time, serum blood glucose, administered activity, etc. So I'm going to go through a couple of examples of ways that we've tried to develop metabolic response criteria. The first of these is Deauville response criteria. The Deauville consensus group was convened in Deauville, France in 2009. This was a group of hematologists, oncologists, and nuclear medicine practitioners looking at Hodgkin's lymphoma. And what they did is developed a lexicon for use of PET-CT for response assessment. They said that a baseline PET-CT is mandatory. An interim PET-CT should be performed within 2 to 4 cycles of the initiation of therapy. And they put the response into these 5 categories. So this is essentially a lexicon to denote the degree of response in patients with Hodgkin's lymphoma. Either no uptake, uptake less than or equal to the mediastinum, uptake greater than the mediastinum but less than liver, uptake moderately increased above the liver, or markedly increased at any site. So here's a patient with lymphoma that's undergone chemotherapy. We can see that this is a very good response. The residual masses show only background level activity. And so this would be either a complete response, or in this new lexicon, this would be Deauville category 2. A patient being treated with Hodgkin's lymphoma, we can see that there's partial response initially, but then progressive disease. But in all cases, this is Deauville category 5 with intense disease. Deauville has its limitations. It lessens but doesn't eliminate inter-observer variability. Not everything hot is disease, so just by calling intensity doesn't necessarily make that lymphoma. And currently it's only applicable to Hodgkin's lymphoma, and it's not really being extended to other tumor types. Many of you may have heard about PERSIST criteria for response assessment. This was a study that was published in 2009 by Heather Jacine, Rich Wall, and colleagues at Johns Hopkins, proposing a PET response criteria for solid tumors, looking at it on a continuous scale. They use the lean body mass SUL. So this is a peak SUV that is based on lean body mass rather than body weight. Now, one of the limitations of PERSIST is when you look at the rule set, this is what it looks like. It's a very complex system and very difficult to use unless your software for PET-CT interpretation is actually designed to obtain these measurements. And the latest generation of PET software is increasingly incorporating PERSIST into its measurement tools. The lesion has to be at least 1.2 centimeters in size, and it calculates the peak SUL, which is a volume of interest placed around the hottest pixel within the tumor mass. You measure the single hottest lesion and then look at that over time. Now, that single hottest lesion may change from scan to scan, so you're not necessarily measuring the same lesion at baseline as you are in follow-up. That's one of the interesting things about PERSIST. And I'll show you what these look like. The lexicon is the same as it is for RECIST: complete metabolic response, partial metabolic response, stable metabolic disease, and progressive metabolic disease. So a couple of case examples. This is a patient with metastatic GI stromal tumor. You can see that the patient has a tumor mass in the left gastric space, has an SUL of 11.5 at baseline. After therapy, the SUL is decreased to 7.0. So in the terminology of PERSIST criteria, this would be a partial metabolic response with a 39% decrease in SUL over a 31-week period. Another patient with lymphoma of the spleen had an SUL of 3.1 at baseline, goes up to 16.9 after therapy. So this is progressive metabolic disease, a 545% increase in SUL over a 10-week period. Finally, illustrating the change in the lesions from baseline to follow-up. This is a 22-year-old with metastatic Wilms tumor. At the time of initial assessment, the hottest lesion had an SUL of 3.5. In follow-up, there's a new index lesion that's actually in the left anterior abdomen, has an SUL of 4.6. So this, again, is progressive metabolic disease with a 31% increase in SUL over a 15-week period. The direction things are moving in the last few minutes of this presentation are of semi-quantitative and volumetric response criteria. These are really an evolution, but there are parameters that can be derived from PET-CT, making use not only of the intensity of activity, but also of the volume of disease, things like metabolic tumor volume and total lesion glycolysis. And again, increasingly, the software tools used for PET-CT interpretation are incorporating these criteria to be able to derive a lot of information from these regions of interest. So here's a patient with newly diagnosed lung carcinoma. Not only might we want to know that the maximum SUV in this case is 12.7, but this lesion has a total glycolytic activity of 470.97 and a metabolic tumor volume of 80 cc's. Those pieces of information may have some prognostic information and may help us quantify the degree of response. And in fact, we're seeing data in the literature coming out, such as in this study from 2013, where they looked at patients with early stage lung carcinoma and found that not only is SUV max predictive of outcome, as we've known from multiple studies in the past, but total lesion glycolysis and metabolic tumor volumes can also stratify patients between responders and non-responders. So the conclusion of this study was that volume-based PET-CT parameters are independent predictors of survival and may provide additive information to standard predictors such as nodal staging and SUV max. We can use this for other types of scans as well. This is a sodium fluoride bone scan performed with PET-CT. We can actually perform these volumetric assessments, again denoting maximum SUV, tumor volume, and total lesion glycolysis. I think it's really going to be helpful in the future for cases like this, where there's widespread disease, very difficult to put measurements around individual lesions, but clearly there's been a positive response to therapy even 8 days into therapy. And to be able to put some quantitative and volumetric parameters on this to quantify that degree of response, I think will be very helpful in the future. This is a DOTATOC study with gallium-68, again demonstrating that we can derive some of these values volumetrically, which may have some added information. There are some unanswered questions, so this is very much a field in evolution. We need to know the timing of response. We need to characterize the response characteristics of various tumors. An example of a patient with ovarian carcinoma, we have a baseline PET-CT scan that shows areas of disease within the peritoneal cavity. And 1 week into chemotherapy, we can see a positive response. But the question is, how do we characterize this response? What does it mean that the degree of activity is decreasing over such a short period of time? Another patient with Ewing Sarcoma, the SUV has gone down from 7.8 to 5.3 within 1 week of therapy. Again, we know this is a positive response, but we need to know exactly what that means for the prognosis in this particular patient with this particular tumor type. Also, a word of caution about inter-observer variability. This was a study that looked at these parameters, total lesion glycolysis, metabolic tumor volume, and they took individual tumors and measured them with various ways, including SUV max, SUV peak, which would be persist, SUV mean, and SUV total, or total lesion glycolysis. The denotations in black indicate that for all four measurements, the conclusion was the same: stable disease, progressive disease, responding tumor. For all of the ones in magenta, they got different end results depending on the method used. They got progressive disease using one value, stable disease with another, stable disease with one value, response to therapy with another. There's a lot of variability in these measurements, and particularly as you start to do volumetrics, it may be difficult to get different readers to do things in the same way. So I do add a word of caution with regards to that inter-observer variability. But future trends, I clearly think we're moving in the direction of these volumetrics. It's always made sense to me that not only do we want to know the intensity of disease, we also want to know the extent of disease or the volume of disease that's involved. And I think that will carry additional prognostic information that will be of great value in the care of patients with advanced malignancies. So we've seen an evolution from RECIST 1.1. I didn't mention the Chasen criteria, but that's been used for a number of years with PET. We're moving into Deauville and PERSIST criteria, but increasingly I think we'll see additional studies being done with these volumetric parameters to really make use of the extent of information that's acquired